Good morning. Thanks very much, Mike and Rich, Sages, for the opportunity to share our research. A point of disclosure, this study was funded by C.R. Bard, the manufacturer of a poly-4-hydroxybutyrate mesh. Obviously, incisional hernias are exceptionally common. Recurrence rates continue to plague us, and arguably, an incisional hernia is the most expensive complication of a midline laparotomy. We know that mesh has been accepted as the gold standard for incisional hernia repair. However, long-term data suggests that recurrence rates continue to plague us, with recurrence rates well in excess of 25%. And mesh is not without complications. Although infrequent, mesh can require removal due to long-term infections, erosions, contractions, chronic pain, as well as recurrences. A recent study in JAMA Surgery has demonstrated that the benefits of mesh are offset by mesh-related complications in the long term. And data generated from our institution has demonstrated that a mesh infection is the most costly complication of a mesh hernia repair. Recently, there have been many absorbable meshes that have come to market. Some have been available longer term, with various different compositions and materials, with various different degradation times ranging from as little as 2 months to as long as 36 months. This study evaluated the impact of a poly-4-hydroxybutyrate mesh material utilized in synthetic mesh repairs. P4HB is a knitted, absorbable mesh material that contributes strength to the abdominal wall for approximately 12 months, is completely resorbed by 18 months, and it looks and feels very similar to most macroporous synthetic mesh materials. Prior in vitro degradation studies have accelerated the degradation of the material, and predictably you can calculate the residual mass, molecular weight, and strength of the material at various time points. And when you correlate the molecular weight of the material to the burst strength, you can see over time the degradation of the material increases, and essentially at 12 months period of time there should be no contributing strength from the mesh material. So this study evaluated ventral incisional hernias using P4HB mesh in 121 patients across 16 centers throughout the United States, with first enrollment in October of 2013 and last patient enrolled in January of 2015. Inclusion criteria included incisional hernia repairs with or without component separations, with mesh placement either as an onlay or in the retrorectus position only. Defect size criteria included hernias at least 10 centimeters in size, with hernias no greater than 350 square centimeters, and they had to satisfy one of the below criteria that were deemed to be high-risk characteristics for either recurrence or for complications, and they include a body mass index of greater than 30 but less than 40, active smoking, COPD, diabetes, immunosuppression, coronary disease, steroid use, hypoalbuminemia, advanced age, or renal insufficiency. Notable exclusion criteria included patients who had had 4 or more prior hernia repairs, a BMI greater than 40 kilograms per meter squared, ASA class 4 or 5, as well as a surgical wound class anything other than CDC class 1. There are other exclusions listed as well. Primary endpoints included hernia recurrence rate as assessed by physical examination at 6 monthly time points out to 36 months. However, patients that underwent incidental imaging studies for whatever unrelated reasons that were noted to have a hernia recurrence were also included as hernia recurrences. Surgical site affections were similarly categorized using traditional CDC categories, and secondary endpoints included things such as visual analog pain scores, device-related complications, reoperations for any reason, quality of life such as Carolina's Comfort Scale and the SF-12, and typical hospital demographic and follow-up information. 121 patients were enrolled, as previously stated, of which 97 have completed 18-month follow-up time points. The average age was 55, with a BMI of approximately 32. As you can see, the overwhelming majority of patients were morbidly obese, although a significant number of patients had cardiovascular comorbidities, diabetes, COPD, or smoking status. The patients enrolled were included primary umbilical hernias at approximately 14%, recurrent ventral hernias in 12%, primary incisional hernias in 44%, and recurrent incisional hernias in approximately 29% of patients. The average defect size was approximately 115 square centimeters. Mesh size was 580 square centimeters. Surgical times were a little less than 3 hours, and the vast majority of patients had some form of concomitant procedure, although included in this was adhesiolysis. 36% of the patients had a retrorectus repair without any additional release of the external oblique or transversus abdominis. 37% of patients had a retrorectus repair with component separation, the majority of which were transversus abdominis releases. 24 patients had an onlay without component separation, and 8 patients had an onlay with component separation, all Ramirez-type component separations. At the 18-month follow-up time point, there have been 11 recurrences, 5 of which were in the retrorectus position, 6 of which are associated with the onlay. There's been 13 total SSIs occurring in 11 patients, the majority of which are superficial, although 4 of these were deep site infections. There have been 7 patients with seroma requiring intervention. Interestingly, I failed to mention earlier is that part of the criteria for study criteria was placement of mesh with a minimum of 5 centimeters of overlap relative to the defect size in all dimensions. 8 of the recurrences in the study involved mesh placement, which did not include 5 centimeters of overlap in all dimensions. Visual analog pain scores continue to improve over time points out to 18 months. So in summary, repair of a hernia with a poly-4-hydroxybutyrate mesh has promising outcomes at 18 months. There's been a low incidence of hernia recurrence, SSI, seroma requiring intervention, reoperation and intervention and adverse events, and ongoing follow-up is continuing out to 36 months. Thank you very much.
Good morning. I was just curious on your criteria to include the patients of those who are smokers, high BMI, or diabetes. So if you're using this for those high-risk patients in clean cases, is the thought that then you'd use it in emergent situations, as we kind of see data that shows to reduce the BMI prior to surgery, have them have smoking cessation to be able to reduce their complication rates?
Yeah, I guess I didn't completely understand the question, but the concept of the thought with using an absorbable mesh material is so that you're minimizing the likelihood of mesh removal in the event of an infection of some type. Having said that, the criteria for this study are fairly they're fairly rigorous, but at the same time, they don't include patients that are anything other than clean. So these are deemed patients who are high risk for surgical site infections. We don't know the long-term outcomes with absorbable mesh alone compared to synthetic mesh, and as this is not a comparative trial, it's hard to glean that type of information. But my personal bias is that if you can repair a hernia or identify patients who can have a successful hernia repair without long-term mesh, there may be some advantage to that.
Okay.
Thanks, Scott. I really appreciate it. It was great talk. Oh, okay.
Did you have a question?
I was going to.
Hey, Scott.
Sorry, I was just gonna. I was gonna ask one other quick follow. No, big deal.
We wanted you to come back.
It's fascinating. It's a really interesting topic, and obviously, you guys had a lot of sites participating and everything. My other question: are there any ongoing studies looking at class 2, 3, 4 wounds to show the efficacy of this mesh? Because obviously, that's still kind of an area that's out there about. I think there's still a ongoing question of what's the safety of permanent mesh, and if we can find something that's reabsorbable, and how effective would it be in those wounds?
Right, so I think baby steps. I think demonstrating efficacy in lower risk populations prior to moving forward in higher risk populations is a prudent way to proceed.
Sure.
Having said that, I know Yuri Nowitzki's been involved in an all-comers trial, which has been published in poster form. I haven't seen the publication, but looked at all levels of contamination. And I think about 2/3 of the patients in that study were not clean wounds. So there is ongoing work in that arena as well.
Great.
Good.
Thanks again.
Great job.